What up? What's going on? What's going on? What's going on? I just had a 12, 13 hour day, so I am tired, drained. I don't even know how many procedures I had today. Anyway, yeah, there you go. Gunner, you guys like that question? See, it's got such of a negative connotation to it. Everybody's afraid to use it in a positive sense. What up, what up, what up? Yeah, so what cases, again, I'm tired, man. It's been a 12, 13 hour day. What cases did I have? Oh, and then I was dealing last night, that's right. It was a crashing patient, stayed late in the ICU. Was helping them out. What did I have today? I had a couple of neph tubes, renal biopsies, liver biopsy, bunch of random lines. I don't know. All the good bread and butter stuff. It was nice. Last final before graduation. Woohoo! Registry review class. 2 years of material on one test. Oh, seriously, you should not be on here. They need to go study. Liver lesion consult from the East Coast. Yeah, seriously, man, that stumped me. Radiology guy's asking. He sent over an image, which was hard, very hard. Dude, the T2, I'm telling you, it was not. That T2 really pissed me off. It was kind of annoying because on the, and this is only he and I know what I'm talking about, and nobody else knows. But the T2 was weird, and then the echoes, there's like posterior acoustic shadowing on the ultrasound. I don't know, really weird. Once you biopsy, let me know. Did anybody else give any other answers? Look at those googly eyes. Anybody else come up with some any other differentials? I don't know. Just put a needle in. It's gonna be. Oh, what I was thinking though. I think you sent me the arterial phase. If you had a really, really delayed, maybe it was just a really slowly enhancing lesion. So if there's like a super delayed phase, maybe a coronal post, it's like 5 minute delay. Maybe something was enhancing. Anyway, case of the day. God, allergies still going crazy. Case of the day. What'd you guys think about it? Got a lot of good answers. Oh, let's see. Hematoma is too solidy on T2, so I don't know about that. Indolent abscess again. The T2 sucked. Endometrioma. No, everyone put a needle in it. Yeah. God, man, that's crazy. That was a hard case. I don't know. Very hard case. That T2 just kept pissing me off. Oh, come on, Alex. You didn't even review the case and you got it? Oh, man. Anyway, let's do a little case of the day action, shall we? I'll put it up right now. I'll put it up. Hello. All right, let's put it up. Where is it? Here we go. Bam. All right, what do you guys think? I got a lot of mixed responses. First of all, tell me what kind, and if you've heard my cases of the day in the past, they're on YouTube right now on my channel. Go to the bio, blah, 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 right. So, first of all, let's break it down before we even start diagnosing. What kind of image is this? What study is this? You guys shout it out. What study is this? What did you order? Now, I'm asking for a reason. Because, yeah, it's an Xray, but kind of. Okay, and the reason I'm asking, I'm being all, like, stupidly mysterious about it, is remember we've talked about in the past. Okay, good. I'm glad everybody's answering Xray. Remember we've talked about, Topo, there you go. We've talked about in the past that a KUB, kidneys, ureters, bladders, a KUB Xray on an adult. Remember, we don't have an X-ray plate that is big enough to cover from the middle right chest all the way down to the inferior pelvis. You don't have an X-ray plate long enough on a normal size adult. So this is a normal size adult. So I've mentioned before in the past, whenever you see an image like this, that kind of looks like an X-ray, but it kind of looks weird as well. It's like kind of grainy. You don't really see the bones that well. You're like, I don't know what this is. This is a scout image for a CT scan. This is the first thing that the CT tech does to say, all right, well, I'm at the middle of the chest. Well, that's a little too high, so maybe I'll go a little bit lower at the top of the hemidiaphragms, and then I'll go down to the pelvis. Maybe it's a little too low, so I'll raise it up a little. And then they do the CT scan. So they do this scout image first, and then this kind of directs them where to go as far as taking the actual CT image. So this is a scout film. That being said, if it's a baby that we're talking about and there's unfused joints, unfused apophyses, epiphyses, all that, yes, you can have an image from the chest and abdomen as an X-ray. That's called a babygram or a chest and abdomen X-ray because it's a baby. The baby is small enough to fit on an X-ray plate. All right, so we've covered that. Now, this is what I want to tell you. A lot of people will look at a CT scan and they'll sit there and go, man, is this an obstruction? Is this normal? What is this? And sometimes when you start off with radiology, it's kind of tough to figure out what it is off a CT. So my piece of advice, and this is what I started doing as like a first, second year radiology resident, I pass it along to everybody, is if I'm unsure of the diagnosis off of the CT scan, I go back to the basics. I open up this scout film and I look at the bowel loops and I say, if this were a KUB sitting in front of me right now, what would I call this? And this is exactly what you can do for this study right now. If you were questioning, is this an obstruction or is this an ileus? Those are the two main things that you guys are debating between. And we're going to talk about why. So sometimes it can be very hard. Is this obstructed or is it an ileus? Go back to the basics. Open up the scout film of the CT scan and say, read it as if you're reading a KUB. So that's number one. Is the air pumped in or part of the abnormality? Good question. The air is all abnormality. All abnormality. All right. So now we get to figure out the top two differentials that everybody's basically debating between. Is this an obstruction or is this an ileus? First, let's define what an obstruction is. All right. Where can things be obstructed? They can be obstructed anywhere from the mouth down to the anus. Anything can obstruct. All right. Based upon the obstruction site, everything proximal to it will dilate up. Say if somebody had an obstruction for some reason right here. They have, I don't know, they have an esophageal malignancy in the mid portion of the esophagus and it's obstructed. It's constricting the esophagus. Everything proximal to it will be dilated up. So the patient's proximal esophagus will be dilated up. Say the patient is a young patient and has duodenal atresia. Well, that's obstructed. That's why they get the double bubble, right? Because everything proximal to it. Some of you guys may be like, dude, why are you trying to like make this so, this is easy, right? Some of you may be saying that, but I want you to take the same kind of concept of what I'm talking about and then relate it to large bowel obstruction and small bowel obstruction, right? Because there's a big difference. And if you think about it in that sense, that whatever is obstructed, everything proximal to it will be dilated up, then you can kind of figure out, well, where the obstruction is. And that's what we call transition points, all right? So let's talk about a small bowel obstruction. If somebody had a small bowel obstruction, what are the parts of the small bowel? There's the jejunum, right? And that's right after the duodenum. And then you can go down to the ileum. Sorry, I should have started off with the duodenum. There's the duodenum. Then there's the jejunum, the feathery portion, and then the ileum down here, right? So those are portions of the small bowel. So if somebody were to have a small bowel obstruction, there could be a small bowel, I don't know, maybe in the ileum somewhere, right? Think about a Crohn's patient. Crohn's patient's terminal ileum. That should be like knee-jerk to you guys. If I say Crohn's patient, you say terminal ileum. That's knee-jerk, all right? So let's talk about a Crohn's patient who has an active flare in the terminal ileum. Therefore, it's going to constrict in that area. It doesn't necessarily have to, but oftentimes it does. It's going to constrict in that area, tighten off that terminal ileum. Everything proximal to it is going to get obstructed. It's going to dilate up. So the whole small bowel is going to be dilated up. Well, guess what? nothing's really making it past the terminal ileum, so not much stuff is really going into the colon, right? Because it goes terminal ileum, ileocecal valve, cecum, and then the rest of the colon. Therefore, a lot of the colon is probably just going to be deflated. Nothing's really going into there, right? So that's a small bowel obstruction. Now let's go to a large bowel obstruction, which is actually not as common as a small bowel obstruction. Small bowel obstructions happen all the time. They can happen I shouldn't say transit. Yeah, sure. They just happen all the time. Large bowel obstructions, not as common. When somebody has a large bowel obstruction, be very, very careful about an apple core lesion, some sort of malignancy, colon cancer. Other things can cause it as well, but those are the main things that you need to start thinking about. So if you have a distal large bowel obstruction, say in the sigmoid colon cancer causing the apple core lesion, it's going to constrict everything proximal to it, meaning the left hemicolon, the transverse colon, the right hemicolon, and all the small bowels are all going to be dilated up. So then you can tell me, well, hey, is this what's going on in this case right now? So two things you need to figure out. Number one, is this large bowel, is this small bowel, or is this both? How do you tell the difference? All right. First of all, just off of morphology and let's go off of just off of positioning. Just off of positioning, normally, this is colon. That's it. That's normally colon on the peripheries of the abdomen, and then the sigmoid goes down like that. That's normal. And then small bowel, it does one of these in the middle. So normally, based upon positioning, that's what you see. So if I see this, and I just see a jumble of air everywhere, everything's dilated up, middle, sides, peripheries, everything. I'm like, all right, it's probably small bowel, large bowel, both dilated up without even like going further into detail. Next, good. Somebody just mentioned haustral patterns. What is haustra? Haustra is part of the large bowel. What makes up the small bowel? Valvula convente or plica circularis, whatever you want to say it, right? You want to be fancy about it. How do you know the difference? We've talked about this in the past before. Look at that colon near the hepatic flexure. All right, haustral folds do not go all the way around. They don't go all the way concentrically around the colon. They kind of stop in the middle. And again, I know for people who have tuned in before, like we've talked about this many times, but I'm trying to hammer home the points. And then the middle bowel, like right in the middle, the small bowel, the plicae, go all the way around concentrically. So that's how you can tell the difference. Then you can kind of try, and then you have to try to tell me, all right, well, we know that both of them are dilated up. So either this is a distal large bowel obstruction or this is an ileus. And then what is an ileus? An ileus is basically large bowel, small bowel, and yes, you can have focal ileus as well. Don't worry about that right now. We're just going to talk about this. It's just a generalized ileus. There's no actual obstruction, but some of the nerves, some stuff, the peristalsis, it's not really functioning properly. And just stuff isn't moving. It's not moving forward. So instead of not moving forward, it's just going to kind of dilate up and fill with air. The bacteria is going to do its thing. Air. Patient's going to, inhale air, that kind of stuff. And they're just going to have this bowel, large and small bowel usually, and it's just going to be filled with air. So how do I know that this is not a distal large bowel obstruction versus an ileus? Well, you have to go to the rectum. Go all the way down to the rectum and see if there's rectal air. There is, in this sense, it's tough to see. If you look at the pubic rami, the two little circles in the bones, right in between that, you can see some air. Again, it's tough to see, but you got to really look for it. So always look for rectal air. Rectal air will tell you that, yes, the air is making it down into the rectum, so it's probably not a distal large bowel obstruction. All right? Who gets ileus or adynamic ileus or paralytic ileus, however you want to refer to it? Who gets an ileus? Think about post-op patients. Think about somebody who just got an X-lap. Think about somebody who just underwent C-section, who got a hip replaced. They're just sitting in bed right now. Their bowels aren't really moving. What actually really gets your bowels to move, and I'm sure you guys have seen this too, go to the gym and go run on the treadmill. That gets your bowels moving. That people have to go and run to the bathroom after that. Yes, exercise gets your bowel moving. So people who are just sitting around, laying around in bed, or are not exercising, not just walking around, their bowels aren't really moving, so they're prone to getting ileus. This is a common thing that you see on post-op patients. Now, I've just mentioned meds. Yes, meds can cause it as well. Opiates. Think about somebody who's on chronic opiates. They can get an ileus all the time. That's what an ileus is. That's what this is, because there's small and large bowel, air filled, dilated up, and there is rectal air, meaning air has made it all the way into the rectum. Therefore, this is not some sort of obstruction. This is all just an adynamic ileus on a post-op patient. That's what this is right here, all right? So don't get confused. Just to recap, whatever obstruction we're talking about, everything proximal to it gets dilated up. And this actually is a very, very key point when you're thinking about sigmoid and cecal volvulus. All right, we'll talk about it later, but it is a very key point. That's why I keep reiterating it right now. It's a very hard point to figure out whenever you're trying to differentiate between cecal volvulus and sigmoid volvulus, which are both emergencies. Surgeons need to know about them right away. When you need to figure out the difference between the two, you look for whatever's dilated up proximally. That makes a big difference. All right. So that's what we have here. An ileus, small and large bowel, dilated up, air filled. Just a recap also from something we've talked about in the past, the usual normal rule of thumb measurements for small and large bowel, 369. It's part of my song that I love singing. 3 is small bowel loops. Above 3, it's kind of abnormal, but usually it's okay. 6 is going to be like your transverse colon, and then 9 is cecum. Cecum is always the largest portion of the bowel. So that's normal, upper limits of normal for bowel loops. All right. Yeah, Physician Doodles knows what song. I'm always singing that song every time I talk about the bowel size. You guys have any questions? Was there anything else that I had asked you guys on case of the day? I don't know. What is that? Wall thickness. Oh, let's talk about wall thickness real quick. Wall thickness, I don't want to talk about it too much right now without giving you examples, because wall thickness can be very deceiving. It can be very, very deceiving. Is if you have a bowel loops that's collapsed and it's just kind of thick because of collapsed bowel, you will be, sorry, I'm just trying to turn this off. You will be fooled into thinking that it's thick because of some sort of abnormality. But you can also have, so if you really want to call bowel loop thickness, you want to make sure that it's kind of dilated up with air or fluid, whatever it is, and then look at the wall thickness. And if it's actually thick, then it's actually a reason for it. And you have to figure out what it is. How much dilation centimeters would be dilated bowel? Same thing. Ultrasound's no different, right? Ultrasound, you're pretty much measuring the same thing. It's the same loop of bowel. Just started following. Hey, good. I'm glad. Thank you. Sorry, I could be a lot more enthusiastic. Not that has nothing to do with. I appreciate you following me. Honestly, I just had a 13-hour day, 12, whatever it was, and then I was in like the ICU, I think, till like 9 last night, working on a patient who was crashing hard. But it was great. It was great. It was a multidisciplinary case, and I was just helping out the ICU team, and yeah, whatever we can do in IR, I was just dropping lines for them, helping them out. What else? What else can I answer for you guys? Oh, I didn't have my second cup of coffee today either. That's what happened. Did have my peanut butter and jelly sandwich though. I make that every morning. Thank you. What else, guys? What else? I need to post something, huh? I'm gonna post something, like an actual post. I'm gonna do that. I've been wanting to. I just need to do it now. Anyway, enough about me. Tell me, guys, what else? Ooh, that is a great question. That's a great question. I'm a crunchy peanut butter guy. Crunchy peanut butter. Crunchy peanut butter, and for years I've been cutting my sandwich kind of right down the middle, up and down, and then over the last couple days I went diagonal, and I feel like a little kid every time I eat it. I love it. All right, so we good with today's case? Yes. Thumbs up from everybody. I know, right? Diagonal all the way, I'm telling you. I literally, I just sit there between cases and eat my diagonally cut peanut butter and jelly sandwich. It's awesome. Like actual measurement value, I read somewhere 3 in the first for large bowel and 2. Oh, you know what you're talking about? No, 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 no. Is it Runok? Runick? Runick. That's probably what it is. I said it the other way with you and the other. What you're talking about, and we'll do a case on it. What you're talking about is intussusception. There's something called small bowel intussusception and large bowel intussusception. And if you look up images of it, go Google it right now, intussusception ultrasound, and it's going to look like a cinnamon bun. Not joking. Large bowel intussusception or ileocolic intussusception, the caliper measures greater than 3.5 centimeters, and small bowel intussusception, which is not an emergency, does not need decompression. It's just transient intussusception. So be very careful if you're dictating that, saying small bowel intussusception. You're going to get a lot of people to freak out in the ED and in the PEDS team, and they're going to want emergent decompression. Small bowel intussusception is not an emergency. It happens transiently, and it'll just go away. And that's greater than 2.5 centimeters. Yes, go to sleep. I am about to. I'm going to eat something right now. I'm not going to the gym. I'm going to go pass out, watch some TV, something. Seinfeld, probably. That's it. All right, guys. Thanks for tuning in. Appreciate it as always. I'm going to go post this right now to YouTube afterwards as well. It'll be on here for the next 24 hours. Any questions, always shoot me a DM. You know how it goes. All right, guys. Later.